Hi everyone, I'm Dr. Mallika. Welcome you all for the Facebook live session. Here we have Dr. Chandana ma'am, one of the best surgical oncologists in Guntur. She has over 4 years of experience. She has completed her MS General Surgery from Andhra Medical College Visakhapatnam and also completed MCH Surgical Oncology from Tata Memorial Hospital, Mumbai. Today we have Dr. Chandana ma'am to discuss about endometrial cancer. We welcome you, ma'am, on behalf of AOI Guntur.
Thank you, Malika, for the introduction. Hello, everyone. Today I'm here to discuss about endometrial cancer. It is one of the less discussed cancers, actually. It is more common in developed countries. It's less commoner in our place, but we need to discuss it because the elderly patients usually experience postmenopausal bleeding and which they neglect. If this endometrial cancer is diagnosed early, the cure rate is very high. Around 90% of 5-year survival is there if we diagnose it early. So we need to discuss about it.
First of all, what is endometrial cancer?
First of all, we need to know about the endometrium. Endometrium is a thin layer which lines the uterine cavity. It's a hormonal responsive tissue. During menstrual cycles, in the presence of estrogen, the endometrial layer has growth and proliferation, and it increases in thickness. And by the time ovulation occurs and progesterone is released, this progesterone hormone will allow the endometrial tissue to mature. It will not let it grow overtly. When the cycle is finished and when pregnancy does not occur, this endometrial lining is shredded off. So if there is cancer in this layer, it is called endometrial cancer.
In whom do we see endometrial cancer?
So it's usually a disease of postmenopausal age group people. Around 80% of the population are above 60 years of age. It still occurs in premenopausal age group. Around 20% of the patients are in premenopausal age group. Around 5% it presents at less than 40 years also. This group we need to discuss in specific because they are younger patients and the purpose of the uterus needs to be served in them.
Mainly who are at risk for endometrial cancer?
So endometrial cancer usually occurs because of chronic unopposed estrogen action. Initially when the estrogen is excess, there is endometrial hyperplasia, and when this continues, it will turn into malignancy, that is cancer. So we see unopposed estrogen exposure in when there is early menarche and late menopause. In these, there are anovulatory cycles. The progesterone is not there to control the overgrowth produced by the estrogen. And we also see this in nulliparous women where anovulatory cycles are high, and in patients with PCOD. Nowadays, we see many young patients with PCOD. Almost 1 in 3 people, 3 females have PCOD. So this is leading to increased risk of endometrial cancer in the near future. And obesity, presence of diabetes, hypertension, the 3 together called as corpus cancer syndrome. This is also a major cause for endometrial cancer. Most of the patients we see with endometrial cancer are obese. This is because of the fat which is converted into androstenedione and again estrogen, which is causing the endometrial cancer. And also in cases of breast cancer, we give tamoxifen to them as a treatment. This tamoxifen drug is supposed to be anti-estrogenic in breast, but it has estrogenic effect on uterus, leading to endometrial hyperplasia again. Around 2 to 3% of patients on tamoxifen will develop endometrial cancer. And 5% of the endometrial cancer cases also have a family history. Lynch syndrome, it's due to a mutation in the mismatch repair gene, which leads to endometrial cancer as well as colorectal, ovarian, urinary bladder tumors.
What are the symptoms of endometrial cancer?
Okay. So as I said, it's mostly seen in postmenopausal age group. The symptom they present with is postmenopausal bleed. So they attain menopause. So what is menopause? Not having periods for a duration of 1 year after 50 years is considered menopause, and getting spotting or whatever amount of bleed after menopause is significant and it needs to be investigated. When considering premenopausal age group, it can be either as spotting or intermenstrual bleeding, or increased frequency of cycles or increased bleeding. Anything can be the presentation in premenopausal age group. So whenever there is an abnormal bleed for more than 1 month, we'll have to investigate it.
How can we diagnose the endometrial cancer?
So whenever they present with abnormal menstrual bleed or postmenopausal bleed, we suggest them, after examination, we suggest them for ultrasound. So we see the thickness of the endometrium on ultrasound. In case of postmenopausal age group, their endometrium is atrophic. If on ultrasound, if it is more than 5 mm, we should consider it as significant and it needs to be further evaluated. In premenopausal age group, the thickness varies. During ovulation, it's around 12 to 18 mm, and during proliferative growth, it could be up to 18 mm also. So if it is more than that, we consider for biopsy. It can be an office biopsy with the Pipple instrument, or in some cases, we can go for DNC or hysteroscopic guided biopsy also.
Ma'am, what are the treatment options, whether surgery or radiation therapy or chemotherapy?
So once the diagnosis of endometrial cancer is made, we need to stage the disease. Usually the staging for endometrial cancer is mainly based on surgery, but preliminary assessment can be made with MRI pelvis preferably, can also use CT. On MRI, we can see the size of the tumor, location, infiltration of the myometrium, involvement of the cervix. Accordingly, we can plan the further management. So once the preliminary stage is made, we plan for surgery. Surgery is the mainstay of treatment in endometrial cancer. It's not only a staging procedure, it's also curative. So the procedure done in endometrial cancer is hysterectomy with bilateral salpingo-oophorectomy, that is removal of the fallopian tube and ovaries, along with lymph nodal assessment. In early stage, when it is confined only to the uterus, stage 1, we just do simple hysterectomy, removal of ovaries, and if it is a low risk disease without involvement of the myometrium, we avoid lymph nodal evaluation also. In intermediate risk for lymph node spread and distant spread, we evaluate the lymph nodes either by sampling or removal of all the lymph nodes. In any malignancies, cancers, lymph nodal assessment is very important. In case of in endometrial cancer, there are 2 types of histologies, like endometrioid adenocarcinoma and serous adenocarcinoma. They are called type 1 and type 2. Type 2 is rare, but it is high grade. In those cases, we also consider to remove, we do peritoneal biopsies and omentectomies. There is a layer inside the abdomen which needs to be removed in case of high-grade tumors. After surgery, depending on the high-risk factors like involvement of the myometrium, presence of vascular, lymphovascular involvement of the cervical stroma, or presence of lymph nodes, we consider for adjuvant therapy. For low-risk patients without any of these high-risk factors, we consider for observation. For intermediate risk, we consider for brachytherapy, intracavitary brachytherapy for 3 sessions. For moderate risk patients, we consider for external beam radiotherapy. If lymph nodes are involved, we consider it as stage 3, and in those cases, we need to give chemoradiotherapy. We also see a set of patients with metastatic condition, but that's less in number, less than 10% only. But still, in those cases, we consider for, like, stage 4 is the disease has already spread to distant organs. There we consider for systemic therapy. There also, if the rest of the sites respond, we can consider for surgery to the uterus. It will be helpful in symptomatic improvement, and also it has therapeutic, it increases the survivals also in this setting.
Is there any other newer techniques?
Coming to newer techniques, I said surgery, we can do it by open technique, and the recent techniques which we are following is laparoscopic and robotic. Laparoscopy is instead of the bigger incision which we give in the abdomen, we give only a small 1 centimeter incisions, 2 or 3 in number, and we access the uterus and lymph nodes and remove them. Similar way, robotic, we use a machine to approach the uterus. This gives us more dexterity, more approach is available, because all these patients, as I said, they're mostly obese, and the location is in the pelvis, which is a very narrow cavity. So the access is difficult in case of open surgery, and it will need bigger incisions. By using a robot, the reach is very good, and with small incision and with good access, we can remove the tumor easily. And post-op also, the patient has lesser pain, early recovery, lesser blood loss. And other newer techniques, we have in metastatic settings, we have immunotherapy also, which is under trials. And in surgery only, we have sentinel lymph node biopsy, which is available for sampling of the lymph nodes. When I said we do lymphadenectomy, there is some problem with lymphadenectomy. We have some side effects. There is lymphedema, swelling of the limbs in 15 to 20% of the patients. There can be lymphocele. There can be increased chance of nerve or ureteric injury. So instead of doing that, we can do sentinel lymph node sampling. Like we give a dye, we see where the dye is going from the tumor. We harvest those lymph nodes and examine them. So with that, without missing the cancer and without causing increased side effects, we can properly stage the patient.
Oh, ma'am, if patient has family history, what do you do?
So as I said, it's only 5% of the patients will have a family history of endometrial cancer. So if the patient has family history, so we consider for genetic testing after counseling. If they have the Lynch syndrome, that is defect in the mismatch repair protein, so we consider them for screening. So starting at the age of 35 years or 10 years before what their family had, we start screening the patient, screening by transvaginal ultrasound as well as biopsies in an yearly. And when the childbearing age is over, once the purpose is served, we consider for prophylactic, that is in advance we remove the uterus even without disease.
Can you give any advice for our viewers?
So endometrial cancer, it has a very good prognosis if it is diagnosed early. So I advise everyone, in case of any abnormal menstrual bleeding, to approach a gynecologist or surgeon to evaluate the reason for it. If there is any abnormality, if you need to go for surgery, if it's a malignancy, better to go for surgery with the surgical oncologist, because you'll have proper staging of the disease. And also to maintain a healthy lifestyle, to take healthy food and not to be overweight.
Thank you, ma'am, for sharing valuable information.
Thank you.